Well, good morning to all of you, and thank you very much for coming to this Directors Forum with Ambassador Randy Tobias, the United States Global AIDS Coordinator. Let me acknowledge here Susan Blumenthal, the United States Assistant Surgeon General. Susan, we're delighted to have you. And I'm not sure whether Connie Carino is here or not. Is she here? She's the Director of USAID's Office on HIV/AIDS, and I wanted to introduce her. She's in the audience. HIV/AIDS is one of the great challenges of our time. It has wrought untold suffering in this country and around the world. It is hard for us to conceive that in several African countries, more than a quarter of the population is infected. The suffering and death caused by the virus has instigated chaos and violence. It has shaken Africa's very foundation. Ominously, HIV/AIDS has recently shown signs of spreading in other parts of the world, China, India, and Russia. Thankfully, important advances in awareness and treatment of AIDS have brought down the levels of infection and mortality here at home. But we have much left to do. It is our business to deal with this global epidemic that causes global suffering and instability. In October of 2003, the Senate confirmed President Bush's nomination of Randy Tobias to serve with the rank of ambassador as coordinator of U.S. government activities to combat HIV/AIDS. The appointment followed an increase in American resources for combating the virus announced in President Bush's State of the Union. Ambassador Tobias's responsibilities include oversight of American HIV/AIDS assistance and coordination of the various agencies and departments that deliver aid. Randy Tobias has had an accomplished career as a manager and innovative thinker in the private sector. From 1993 to 1999, he was chairman, president, and CEO of Eli Lilly and Company. Under his stewardship, Eli Lilly enjoyed a remarkable run of success, and upon his retirement, he was named chairman emeritus. Prior to his work at Eli Lilly, he served in several positions at AT&T, including chairman and CEO of AT&T International from 1991 to 1993. Now, he has the important asset and qualification of being a Hoosier. He hails from Remington, Indiana. Randy, it always surprises me that in the sophisticated Washington audiences, there are more people who have been to Paris and London and Bangkok than to Remington, Indiana. But you and I have been there. He graduated from Indiana University, and his talk today is entitled, "The President's Emergency Plan for AIDS Relief, Stepping Up to the Global Challenge." Mr. Ambassador, we welcome you to the center.
Thank you very much, Congressman Hamilton. It's a great pleasure to be here. Certainly your service to this country and this world is an example to all of us, and as a fellow Hoosier, I am especially privileged to join you here today. And thank you to all of you for being here this morning. Many of you I know representing organizations making contributions to the battle against HIV/AIDS as advocates, as service providers, and as policymakers. Many of you were among the first responders to this crisis, assisting people and communities devastated by HIV/AIDS and generating international momentum against this disease. I have just returned from a trip to Africa, my second since being confirmed 60 days ago, and again I was struck in every country we visited, this time Zambia, Rwanda, Kenya, and Uganda, by the amazing work being carried out in partnerships among communities, non-governmental organizations, governments, and donors of all sorts. Regardless of the barriers imposed by stigma, silence, lack of leadership, or very limited resources, I saw yet again the results that can be achieved in the battle against HIV/AIDS and the new possibilities for intervention that have been illuminated. I stand before you today as the first United States Global AIDS Coordinator with the awesome responsibility and the extraordinary privilege of leading a 5-year, $15 billion effort to combat global AIDS. The President's plan represents the largest commitment ever by a single nation for an international health initiative. There has been nothing like it before in any humanitarian purpose, perhaps since the Marshall Plan. In part, President Bush's decision to launch this initiative is, I believe, a testament to the work of many of your organizations represented here this morning, because you brought voice to the devastation of this pandemic. You helped develop strategies to combat the disease, and you provided armies of women and men serving people and communities in need. I know that many of you are very familiar with the statistics of the global devastation of HIV/AIDS, but they bear repeating as an affirmation of our commitment and in recognition of the people who suffer the greatest burdens of this disease. During 2002 alone, 3 million people died from the complications of AIDS, leaving behind anguished loved ones, abandoned children, and ravished communities. And at the same time, 5 million people became newly infected. Do the math. We are losing the war. At the current pace, we are headed for the destruction of the world, with a great deal of human tragedy and political and social destabilization along the way. 40 million people are infected worldwide, and tragically, very tragically, most of them do not know they are infected. Far too few people are being tested, and that, I think, is one of the initial things that must be addressed and must be changed. This is a disease that is 100% preventable, and so prevention, in my view, is the chief weapon in the spread of HIV/AIDS, and it must be our number one priority. And testing, knowing one's status and what to do about it, is one of the keys to prevention. When this epidemic was first addressed in the United States, discovering one's status was thought to be the beginning of living with stigma and a certain sentence of death. Perhaps without intending to do so, we have exported those same fears to much of the rest of the world. With the availability of antiretroviral drugs, it is now possible for someone living with HIV/AIDS to live a normal, productive life and to eventually die of something else. That's what is possible. But to make it a reality will require an almost unimaginable effort, and that's what we are all now about. Stigma, however, is still a huge issue, an enormous barrier to a number of things, beginning with testing. And I think we must find new, more effective ways to make it both acceptable and desirable for people to want to know their status. In claiming the lives of society's most productive populations, adults ages 15 to 45, HIV/AIDS threatens a basic principle of development, that each generation do better than the one before. This disease has deepened poverty, it has reduced life expectancy, diverted state resources, and left a generation to grow up without the love and guidance and support of parents and teachers. This year, however, may bring the hope of a new approach. The global community is coming into alignment to focus on HIV/AIDS as never before, with every sector, public, private, religious, non-governmental, multilateral, making contributions to the fight. Increasingly, national leaders are announcing that they do, in fact, have an HIV/AIDS problem in their country, and that they do, in fact, intend to put resources and attention to addressing it. Lessons have emerged, and leaders are beginning to take heed. We now have more proven methodologies for combating HIV/AIDS, including effective prevention and behavior change strategies that have produced real results, approaches to fighting stigma and discrimination, and proven programs that partner government with civil society. We know that global and national leadership is essential, that early and effective action can contain and even roll back epidemics and reduce the burdens of the disease. But we're also mindful that the statement by the late Tip O'Neill that all politics is local applies equally to public health. The battle against HIV/AIDS will in the end be won and lost in small places, places so small that you won't find them on any map of the world. I was in one such place last week, a tiny farm settlement in Uganda just outside of a small town called Toraro. There, the Centers for Disease Control of the Department of Health and Human Services is partnering with TASO, a community-based support organization for persons living with AIDS, in a program providing patients with safe water, an antibiotic to prevent opportunistic infections, and importantly, with antiretroviral drug therapy. While I was there, I visited 2 of those patients and their families in their homes, mud structures with straw roofs and dirt floors. Community health workers who are part of this program visit each patient weekly, getting there on small motorcycles to monitor conditions and monitor patient adherence and to deliver the new supply of medication. The progress of these patients since beginning treatment is amazing, and their adherence to the therapy regimen is nearly 95%, much higher than our experience here in the United States. Now, some have opined that ARV treatment is too complex to try to deliver in these kinds of environments. Well, what's even more reassuring about this project is the ability of these community health workers to impart very complicated information that is fully comprehended. Let me give you an example. One of the patients I visited, a man named John, is HIV positive and is on the antiretroviral therapy program. His wife is also HIV positive, and she is not on the therapy. So when I asked John through the translator if there was any conflict in the family, any temptation because he had access to this life-saving medicine and his wife did not, was there any temptation to share his medicine with her? He explained to me that it was not an issue because his CD4 cell count was 162 and he needed the medicine now, but his wife's CD4 cell count was 312 and she didn't need the medicine, but that they understood that when her CD4 cell count dropped below 200, that she too would be put on the program. All of this being told to me in a mud hut with a straw roof and a dirt floor. Understanding can be conveyed, and ARV therapy can be effectively administered in very primitive places. And where there used to be a treatment versus prevention debate, Today, few dispute these are not either-or issues. Clearly, prevention must be our number one priority in order to stop the spread of this disease. That has been the approach in Uganda, and it works. I have visited their primary schools to see how they do it. It is straightforward, relatively inexpensive, and enormously effective. Their message for young people in schools has three components. Be abstinent until marriage. Don't associate with people who will harm you or will try to convince you to do the wrong things. And be a strong person and stick to what you know will help keep you safe and healthy. And then they try to provide the tools and the resources to help people figure out how they're going to do that in some very, very difficult circumstances. But prevention is not the only answer. Where a life can be saved, it must be saved, and that is why treatment is also an imperative. And the implementation of life-saving antiretroviral treatment also provides the incentive for people to be tested and to learn their HIV status, and that in turn contributes to prevention methods. And so there are no bright lines between prevention and treatment and care because they are all interconnected and they all contribute to the desired end result. The United States has stepped up to the challenge of global HIV/AIDS with President Bush's emergency plan for AIDS relief. As President Bush has stated, and I quote, "In the face of preventable death and suffering, we have a moral duty to act, and we are acting." The President's 5-year initiative is targeted to providing treatment medicines to at least 2 million HIV-positive individuals, preventing 7 million new HIV infections, and caring for 10 million people living with HIV/AIDS, including the orphans and vulnerable children who have been directly impacted by the disease. The plan offers $9 billion in funding to 14 target countries in Africa and the Caribbean, representing 50% of the world's population of people living with HIV/AIDS. I have visited in the last 60 days 8 of those 12 countries in Africa, and on Monday I am leaving for Guyana and Haiti, the 2 countries in the Caribbean. The plan also includes $1 billion in contributions to the Global Fund, a very important element in our overall approach. And that will bring total U.S. contributions to the Global Fund to $1.6 billion, more than a third of all of the pledges to date to the Global Fund. And it provides $5 billion to continue our bilateral assistance to nearly 60 other countries worldwide. As I have pointed out to people, President Bush did not name me to be the 14-country AIDS coordinator. He named me to be the global AIDS coordinator. This is a disease that does not respect political boundaries, and we've got to figure out how we are going to address this more broadly. But in the meantime, surely my attention is and needs to be devoted to getting these programs started in the 14 focus countries. The plan begins in fiscal year 2004 with well over $2 billion in funding, steadily increasing to reach a total of $15 billion over the 5 years. We know that we are embarking on an effort unrepresented by any other nation, with the mission of turning the tide against HIV/AIDS, and we will work with target countries to develop the infrastructure, the technical and absorptive capacity to effectively use these funds and to do so as efficiently as we can in achieving results against HIV/AIDS. And we will ramp up our funding over the 5 years accordingly. We cannot and we will not fail in this fight against HIV/AIDS. The House passed our appropriations bill on Monday. The Senate has yet to act. The money for this program is embroiled in the omnibus appropriations bill, and as of the moment, it appears unlikely that we will have any funding before mid to late January. But we have no time to waste. This is a fight in which every day the equivalent of 20 Boeing 747s loaded with people crashes, killing everybody on board. about 8,500 people. And imagine the reaction you would have if you got up every morning and read that in the previous 24 hours, 20 Boeing 747s had crashed. And then you got up the next morning and read it again every day of the year. That is the magnitude of this issue. Although my office is in its very formative stages, we have been able to get moving to develop a strategy and guiding principles such that we can begin to take action against this disease once we receive funding from Congress. A fundamental principle of the overall plan is to develop sustainable prevention, care, and treatment programs. As we do that, we need to keep in mind what Albert Einstein once said when he said that stupidity is doing the same thing over and over and over and expecting different results. I think that applies here. To do this job effectively, in some cases, we need new paradigms. We need to take a fresh look at evidence-based results, at what has worked and what has not, in the variety of countries and communities and populations that will be served by this program. One of the new paradigms is how we organize to attack this issue. I have asked all of the departments and agencies to leave their uniforms at the door, to come together into a single United States government team. I have asked the U.S. ambassador in each focus country to take responsibility for pulling together all of the resources of the United States government in the development of an integrated plan that follows the principles and the guidance that we are providing centrally in order to implement the President's initiative in each of these countries, and then to provide leadership to all elements of the U.S. government on the ground in making it happen. Our activities in this area will now be U.S. government programs, drawing on the strengths and the capabilities of individuals and organizations in whatever way makes the most sense. While the policy decisions and the strategic direction are my responsibility, I feel very strongly that the implementation of our programs must be very field-driven, such that the people on the scene can be responsive to the specific implementation circumstances and the available human and material resources in each country, and can leverage the innovations of field staff and communities and other organizations who are joining the fight. We are well along in the process of developing these plans, and I'm generally very pleased with the work that is underway in most of these countries, and I'm extraordinarily pleased with the attitudes of the people who are involved in putting all this together. I'm pleased to tell you that we have now some mechanisms in place that we hope will allow for the rapid expansion of some existing effective, accountable, and sustainable prevention, care, and treatment programs already underway by groups who have produced results from their work in either single or multiple countries. Proposals are now being accepted between now and the 1st of January from organizations who are able to rapidly expand their existing activities and can demonstrate proven results in 5 target areas. First, HIV/AIDS prevention through abstinence and behavior change for youth, intended to expand and strengthen our primary prevention efforts. Second, rapid expansion of antiretroviral therapy programs for HIV-infected persons, including the provision of technical assistance to develop indigenous capacity to continue antiretroviral therapy programs. Third, the provision of expert guidance and technical assistance to ministries of health and national blood transfusion services for the rapid development and strengthening of safe blood programs. Fourth, programs to support orphans and vulnerable children affected by HIV/AIDS. And fifth, programs to reduce transmission by unsafe medical practices, including in particular the promotion of safe medical injection practices. Now, the point here is not whether or not these are the most important issues, although clearly some are. The point here is to identify and fund programs with proven capabilities that can be scaled up quickly to begin this effort and to begin to get money to those programs and therefore those people who need the help. but this is only to get us started. At the same time, we are putting in place plans for longer-term programs that will involve both current partners and new partners. There is no doubt that HIV/AIDS represents one of the greatest challenges of our time, and it will require constant and concerted commitment from all of us if it is to be defeated. Without intervention, experts predict that over 85 million people will be infected worldwide by the year 2010, with a loss of human life to AIDS totaling 100 million people by 2020. In partnerships with governments, non-governmental organizations, and multilateral institutions, we can maximize our efforts and make real gains in this fight. A fight in which every battle won is measured in the lives saved, the families held intact, the nations moving forward with development, and the future secured. On its own, United States government plans cannot be achieved. We cannot achieve the goals of the President's plan of 2 million on treatment, 7 million infections prevented, and 10 million receiving care. We cannot do that on our own. Nor should this plan and the parameters of this plan represent the limits of our understanding of what is possible and what we can do over time. But working together, these goals should be the stepping stones to a world in which AIDS and the devastation it wreaks are eventually eradicated for all time. That is a goal that is elusive and is probably a long way off. But in the meantime, there is so much that we can do. President Bush has said the advance of freedom and hope is challenged by the spread of AIDS. That is surely true. All who join in the worldwide campaign against AIDS serve on the front lines of freedom and hope, and I look forward to serving with you. Thank you very much.
Thank you very much, Mr. Ambassador. We'll have time for questions. We will proceed till about 11 o'clock, not beyond that time. Keep your questions sharp. No speeches, please. Turn off cell phones and the usual rules we have when we have these kinds of sessions. We have microphones on both sides. Signal to me, if you would, by raising your hand if you want to ask a question, and we'll get a microphone to you very quickly. Are there any questions? All right, we have two here. Let's begin with the young lady here. We'll get a microphone, and then we'll follow the gentleman in back of her. Right here, Nicole. Yeah. Would you raise your hand so she can see you? Thank you.
Hi, I was wondering if you could let us know about how many concept papers were received on Monday in response to the APS that was put out.
I have no idea. I have a stack on my own desk of, like that of things that have come in, and we're getting lots of things. But let me say, we need to find ways, formal and informal and ongoing, to receive not only people's formal proposals for help and assistance, but people's ideas and experiences. We're still kind of figuring out some of that, how to get that done. But I want this to be as open a dialogue as it can possibly be, because we need everybody's help to get this done.
Okay, the question here, and then there'll be another one over here.
So I'm from India. I'm a population leadership program fellow at the University of Washington. And it was a real nice experience learning and listening to your talk this morning. I just wanted to have one information from you, that you mentioned that prevention is the top priority to HIV/AIDS. I really appreciate that. But at the same time, I come from that part of the continent where there are a lot of people infected with HIV/AIDS, and there's a lot of stigma attached, up to the extent that the people are getting stoned to death at times. And the country has announced that, there are certain drug companies which have announced that they can, thanks to the Clinton Foundation, that the drugs cost has gone down to $140 million per person per year. But the companies have announced that they can go further down as low as $70 per person per annum. But there are a lot of patent rules and a lot of other constraints. Because of that, they cannot do it. I would really be happy if you could just tell us if your foundation, if has some plans towards that area, towards the treatment of the people. Thank you.
Well, I'm often asked, are we going to buy or fund generic drugs or drugs from the research-based companies? And my answer to that is yes. We need to buy drugs or to cause drugs to be bought. I'm not sure we're going to actually buy commodities ourselves, but the programs that we will fund need to buy drugs that are safe, effective. If they're generic drugs, drugs that have the bioequivalency and bioavailability of the original drugs, and to do so at the best possible prices. As you say, prices have come down dramatically. They've come down dramatically not only with the generic companies, but with the research-based companies. And many companies have developed pretty extensive contributions programs. So I think one of the issues we need to worry about in this area is, hopefully, if with all of the people who are coming to the issue, is the issue of capacity, the issue of manufacturing capacity around the world, and whether or not we're going to be able to scale that up over time to supply the needs that we have.
A question over here.
I'm reading here, and it says that one of the HIV/AIDS strategies will be through abstinence and behavior change. And we all know that behavior change takes a long time. And when you focus on abstinence, what does this mean for NGOs in these countries which are focusing on other things as well? Will it have a bias against them? Because faith-based organizations are known as the only ones which talk about abstinence. What about other NGOs which talk not only about abstinence but other things? How will this funding affect their work?
Well, the fundamental policy of this program is based on the concept of A, B, C. A for abstinence, B for being faithful, and C for the correct and consistent use of condoms. And I think that's an important strategy for populations, but it's not necessarily an appropriate strategy for individuals. For young people, for example, the abstinence message that you're talking about is very critical. And I think faith-based organizations and other NGOs will be very important in delivering those messages. The policy of the program is that if people propose programs and want to participate in some but not all of the elements of our programs, that's fine, as long as anything they say about the whole ABC strategy is fact-based. So there's no bias, if I understand your question correctly, there's no bias against anybody in this program.
Question here.
Thank you. Good morning, Ambassador Tobias. I'm from Pakistan. I'm also a Population Leadership Program Fellow at the University of Washington at Seattle. We have found that various programs all over the world have, or at least in some parts of Africa, they are giving treatment for prevention of AIDS or a virus from the mother to the child, but the mother is not being treated. How will your office look at that?
Well, that's a very important concept, and indeed beyond that there are a number of both pragmatic and ethical issues, I think, in this whole fight. The President's foundation program upon which this new program is built is the Preventing Transmission from Mother to Child program, and I think it's been a very important effort, not only in terms of the results it's achieved, but it was a beginning effort to get agencies and departments to figure out how to work together across borders. But as you say, it is a program directed at saving the babies, and we need to add to this program, and this program is being swept in, or has been swept in now under the emergency plan. We need to begin to address the mothers and the fathers and the siblings who are involved in these programs. The single most effective program that we could possibly put in place for orphans is keeping mothers alive. And we need to try to do that.
Okay, let's see, we have one back here, then there are two here. There are so many hands up, I'm having difficulty keeping track, but I'll do the best I can. Go ahead, please.
Thanks. I'm from a foundation for hospices.
You wave at me, I don't
She's
see
way
where
in the
you-
back.
Oh, yeah, okay.
Sorry. Hi. I'm from the Foundation for Hospices in Sub-Saharan Africa and really looking at the palliative care component of the President's plan and wondering if you have some plans in terms of when that's going to come up and how we can start to deal with the deaths that are happening every day.
The palliative care aspect of this program is not included in what we are calling the Track 1 programs that we hope to get out in January, but it certainly is going to be a very important part of the programs that will generally focus on the rest of fiscal year 2004. I would have to confess that before I came to this program, I was really not familiar with the concept of palliative care, and I've come to understand that there are various understandings and definitions of exactly what it means. And in fact, quite coincidentally, I spent about 45 minutes yesterday afternoon with 3 doctors in a discussion about what does it mean and what is it going to include and so forth. But it clearly is going to be a very important aspect in that it's one of the components of the 3 goals of prevention, treatment, and care. So your opportunity will come.
All right, a question here, and then we'll follow there.
Good morning. I'm from the World Council of Credit Unions. You heard from my Kenyan counterpart last week.
I did. In
Kisian.
fact, yes, I did. I was at a display and a
Yes.
fair with.
I was
yeah.
standing with him. Anyway, he was telling you about the emergency borrowing of credit union members and describing how credit unions could be a network for prevention information. I'm wondering if you're envisioning any programs that will support access to financial services so that HIV/AIDS households can better support the costs of medical expenses, hospitalization, funerals, orphan care, including school fee and shelter.
Let me, if I might, answer your question more broadly, because I say at the outset that I'm personally, there are probably people who have thought about this, but I personally haven't been into specific detail there. But you raise a very important conceptual point. The President's program is focused on prevention, care, and treatment. One of the challenges I'm going to have is to keep it focused on prevention, care, and treatment, while at the same time recognizing that it's hard to draw bright lines in these things. For example, it doesn't make a lot of sense to put somebody on antiretroviral treatment if they are starving to death and they don't have clean water. But that's where I think coordination is going to be so important with the Global Fund, with other bilateral programs, with the World Bank, with other donors. As it happens, someone that Congressman Hamilton and I have known for a long time, Jim Morris, is heading the United Nations Global Food Program, and he and I have had a couple of discussions about ways in which we can coordinate our efforts with the food efforts of the Global Food Program. I think the President has made an important conceptual decision in focus. I'm a big believer in focus. And it's my job to try to prevent this from becoming an inch deep and 10,000 miles wide, or we aren't going to get anything done. But at the same time, I can't ignore the fact that we need to relate to other programs, and that there are lots of other places that can deliver information and approaches that are important. The private sector, for example, is going to be very important in this. Workplace programs focused on dealing with stigma may be among the most important ways to deal with that stigma. So you certainly represent a very important asset here.
Here sometime next year. A question here, and then in the back.
Ambassador, thank you very much for your leadership in this campaign. My question was building a bit on a previous one, I think a gentleman from India, regarding the question of procurement of the pharmaceuticals here. I wonder if I could draw you out a little bit on that. Certainly the urgency is there. I wonder what your own timing and your own criteria will be. My understanding is that the law that establishes your program calls on for the purchase of lowest cost, not necessarily lowest price drugs. There are a lot of intricacies in that you will well know, and many people here. I just wonder if I could draw you out a little bit about what decision criteria will you take? When could we expect some decisions with respect to generics versus the ethical?
Well, first of all, let me remind all of us that I was confirmed 60 days ago, and I've spent a third of that time in Africa. So this is very much a work in progress, but we're thinking our way through those very important issues. The World Health Organization has a process by which I've forgotten what the word is, but they sort of authorize or designate as official certain drugs. We're having discussions with the World Health Organization about the appropriate role that perhaps organizations around the world like the Food and Drug Administration ought to play in having a very transparent process for looking at drugs, because we've all come to believe that we can depend on drugs in terms of what they're going to do. And we've begun to understand, I think, in the last few months that there's a growing problem around the world with counterfeiting, that issues of bioequivalency are important. But by the same token, there are generic drugs that are wonderful. So somehow we've got to find the way to do this that gives us the lowest cost and delivers drugs that are going to get the job done in terms of safety and efficacy. There's another thing that I suspect that many of you in this audience understand, but I don't think the general public does, about antiretroviral drug treatment as it relates to other things that we've had experience in our lives. Just in conversations with people, I think there are a number of people who may sort of see this like cancer treatment, for example, that you identify a patient, you put them under treatment, you get the disease under control, and they see their doctor every 6 months. These patients, based on what we know now and in the foreseeable future, once they are started on antiretroviral drug therapy, must stay on a consistent, disciplined regimen of antiretroviral drug therapy every day for the rest of their lives. If they proceed for 2 months or 2 years or 6 years and get to a point where their CD4 count and other indicators would sort of indicate that the disease has disappeared, if they stop the therapy in a matter of days, they're going to be right back to the reference level where they started. So this is a long-term commitment, and issues of drug resistance are very important considerations over time. I want to make very clear, I'm not a scientist. My understanding of these issues is based on what other people have told me and what I've learned over time. But this is not as simple a silver bullet as it sometimes is made out to be when we talk about it and read about it, and it's going to take care. But it's critically important, not just for the treatment, but as I said in my prepared remarks, antiretroviral drug therapy is one of the reasons that gives hope to people and causes them to want to know their status and get tested, because it no longer means that knowing you're positive has to be a death sentence.
Question here, and there'll be one here, and then in the back.
Yes, I'm also one of those who's happy to hear you stressing prevention as the highest priority, I guess, and the related behavior change to get us there. It does strike me, though, that focusing only on youth is fairly narrow. Yeah. Even though youth are fairly important, you have this older man, younger women dynamic. You have issues still, commercial sex workers being very important. And also the issue, some evidence that a general societal norm is actually pretty important to influencing everybody's behavior. So I guess I'm wondering if you're going to support other efforts that are broader than just.
Yeah, in the amount of time available in a forum like this, one runs the risk of using an example and having that interpreted as being the program, and I don't intend that. It's just an example. There are a number of issues here that are incredibly complex, and the issues related to the vulnerability of young women is extraordinary. I was in an area in Kenya last week where the HIV incidence rate in young women between 15 and 19 in this particular piece of geography is 23%. The prevalence, and it's the prevalence rate of young men 15 to 19 in exactly the same geography is 4%. And there are a whole lot of complex issues, some of them cultural and some of them exploitive, associated with all of that. We need to understand those things and deal with them. But the reason that I say prevention is the number one priority, this is a subject where it probably doesn't make any sense maybe to say something is the number one priority because it's all systemic and we need to do it all. But, you know, if 2 million people died, or 3 million people died in a year and 5 million more got infected, and we keep that up, you know, we're not making any progress. So treatment is important, care is important, all these elements are important, but unless we address the prevention issue, we're going to keep having to deal with the treatment and care going forward. So we got to get the problem stopped while at the same time we're dealing with the problem that exists.
Okay, question here.
Yeah, Ambassador Tobias, I was very heartened.
Sorry, can you? I should tell you that I am at the age in life, and I have spent too many times in noisy factories that I am now wearing hearing aids. I introduced President Reagan some years ago and was instructed that in the Q&A period, my job was to be sure to designate to him who is asking the question, and I now understand why.
Questions on the wall.
Over here. Yeah, I was tremendously heartened that you began your speech talking about the importance of fighting stigma and imparting the understanding about how the stigma around HIV inhibits a lot of the other efforts, even at basic things like prevention. I'm aware that USAID in Africa has a policy with its international visitors programs that to be eligible for these, students have to be screened and tested for HIV and report this to AID, and if they're HIV positive, they're excluded from the program. I'm wondering if this is not inconsistent with this stigma policy, and is maybe this worth reevaluating?
I'm not familiar with that, so I really can't comment on it. Other than to reinforce what I said earlier about stigma. We've got to do something if we're going to get people tested to get rid of the stigma, and this is a place where a number of things can be done. But one of the I think most important is for people in leadership positions to step up and deal with the stigma issues by getting tested publicly themselves. It is my intent as I travel around Africa to every place I go to a testing place, I intend to get tested. I just think it's important that people in leadership roles put their money where their mouth is, so to speak. There's an old saying that your actions speak so loudly that I can't hear a word you're saying. And we need to demonstrate that the importance of all this in every way we can.
Okay, question here, and then there'll be one in the very back. Yes.
Thank you very much for your comments. I'm from the Fogarty International Center at National Institutes of Health, where we're involved in capacity building in developing countries. I wanted to get your thoughts, going back to your numbers, about the enormous ramping up of getting to 2 million people on therapy, particularly in these countries which have limited health resources. And you described the program in Uganda where they were using community health workers. And when you get to Haiti next week, you'll see Paul Farmer's
I'm going to spend time with Paul Farmer next
which
week.
uses community but it involves enormous amounts of training. And I guess I'd like to hear a little bit from you how you see the training taking place through which is this going to happen all over there? Is it going to happen by bringing people here? How do you anticipate those huge needs both in prevention and treatment being met? That seems to be a pretty important early step.
Your question, I think, underlines 2 points that I've made before, and let me make them again. And that is that it's easy to talk about these treatment programs in very simplistic terms and leave people with the impression that if we just fill up the warehouses with the drugs, we've got the problem solved. And it's much, much more complicated than that. Secondly, I think we've got to find some new innovative, well, let me make emphasize the other point, and that is that the government can't do this alone. We've got to do it with host governments, with NGOs, with lots of organizations that have lots of creative ideas. I was in a facility last week that I probably don't have the name exactly right, but the Association of Physicians that are focused on infectious diseases. Right. And they have a program. They've already trained 150 in about a year. They've trained 150 healthcare workers in this facility. Very, very innovative. The particular program I was describing, where the community health workers go out on motorcycles, these are people who are not healthcare professionals. They have limited training. They work under the supervision of healthcare professionals. The one I happened to go out with had been a social worker prior to coming into this program, so he had some experience in dealing with human beings. But they came from, some of them had been teachers or accountants or, various things. I've had some discussions at the Defense Department with Dr. Winkenwerder, the Assistant Secretary, about the possible use of training techniques and experiences that the Defense Department has had. I've talked to the Peace Corps about whether or not there might be possibilities for some sort of new program of bringing trained experience, maybe people like me who are at a point in their life when they're finished with what they thought their career was, but have skills in the healthcare field. Maybe there are possibilities there. But training people in the United States or exporting people from the United States into these places as healthcare workers is not the answer, because we've got to put in place programs that are sustainable. We have to teach people to fish, not just unload crates of fish on their loading docks. And so part of what we have to do in the long-term programs here, I believe, is to address this issue. I have more questions than I have answers at this point, but the human component in all of this is extraordinary. I was in, I believe it was in Namibia, visiting a pharmaceutical warehouse that the Ministry of Health owns, and discovered that, I think this is correct, that there are 2 pharmacists in the employ of the government total. The numbers of healthcare workers who have left these countries to go to other places is enormous. The problems that all of us who are trying to help are creating in these countries with poaching of healthcare workers. The president of Botswana was describing to me his sort of mixed emotions when somebody new arrives in town, because the good news that help is coming. The bad news is that somebody's probably going to get hired away from the ministry at a time when they need people to deal with this. That's why the coordination is so important. But the human resource thing is just critical.
Mr. Ambassador, we have 400 programs a year here, and we have more questions in this program than in the other 399. We got time for only 2 more questions here in the very back, and then there'll be one over here.
Thank you very much. I'm glad that you took the opportunity to mention what you yourself saw in terms of the starkly higher prevalence rate among young women in Kenya. And of course, that's broadly the case, and that women are infected at approximately 58% in Africa overall. And that leads to the question of how you're going to be able to effectively address the gender component, because it seems to me that if you want to focus on the effectiveness of this strategy and, as you've said, the sustainability of the strategy, this needs to be a clear and strong component of the U.S. policy. And with the understanding that one doesn't want to be an inch deep and a mile wide, there are very important steps that you could take to be making clear that the gender component of this epidemic is going to be a key part of what U.S. strategy is going to aim at. And can you describe what your plans are on that score?
Well, I can't yet, other than to agree with you that it's a very important element of this, and I think that while we are addressing the gender issue, particularly as it pertains to the vulnerability of women, part of the solution to this, I believe, will lie in the messages that we bring to young men who are culturally, many of them living in environments where it's been their custom to not treat women with respect. But the statistics I cited from this particular area in Kenya, as I suspect you've probably forgotten more than I know about this, but this is not a totally unique situation, and there are a lot of reasons for that. We need to understand what they are. We need to understand what people who have been thinking about and dealing with these issues understand and can do to help inform us as we think our way through what we're going to do.
Final question here.
I'm a fellow, a population leadership program fellow from University of Washington. I'm from Ethiopia. My question is that in the last few decades, our major problem with regards to implementation of HIV/AIDS program is that there is limited national capacity in absorbing huge donations from abroad, including the World Bank donations, also from donations from U.S. government. Now, the billions are being considered as part of this program. I would still think of the biggest challenge that we'll be facing in terms of absorbing this huge amount of money. And quite often, it would be impossible to do so, and many programs would fail as a result. So what do you have in mind in terms of building the absorption capacity of these countries in terms of dealing with this huge sum of money that's being considered? Thank you.
Well, I've tried to at least touch on that as identifying that as a major problem. Infrastructure, physical infrastructure, as well as the human component of this absorptive capacity is extraordinarily important. And one of the ways in which we need to address this is to be sure that all of the donors are coordinating their efforts to the maximum degree possible, so that we are expending our resources in ways that will most effectively address the need to build up this capacity. By the same token, I'm probably going to disappoint some people because we're not in this program going to focus on broad-based improvements in the healthcare systems that go way beyond what needs to be done in order to address the HIV/AIDS programs. But hopefully what we do will be a component part of what other people will do to address the broader issues here. It's a very important issue that we have to have in mind as we go through this.
Okay, let's express our appreciation to Ambassador Tobias. I am going to leave with your assistant a application. This woman is terrific.
Okay, good.
Terrific.
Okay.
And also both Murray Fishbacher.
Okay.
He's one of the leading experts in the world
Hi.
on Russia.
Nice to meet you.
I'll see that he gets it.
Yeah. Thank you.
Okay.